Thank you very much for the warm welcome. Wish we were there. This, I think for all of us, we were preparing for the trip of a lifetime, but c'est la vie, and I'm glad that we're able to at least meet each other virtually. So let me get started. I tend to overdo it when it comes to number of slides, but if anybody wants copies of this lecture, hasn't received them, or for whatever sort of thing, just shoot me an email, and I'd be happy to send you PDFs or whatever is the easiest way to send this out to you. I'm big on pictures, not as much on text. So a lot of this is going to be just looking at images and diagnostic cues of things. Alrighty, so let's get started on fibroepithelial things. I have nothing to disclose. And the objectives for today are to present examples of fibroadenoma and variants of fibroadenoma. We'll also kind of look at a few cues to help distinguish fibroadenomas from phylloides tumors, which will, I think, as long as the microscope will be used in pathology, will be a difficult endeavor. And then to review common criteria for grading phylloides tumors once we are determined that that's what we are looking at under the microscope. And we still will use the traditional benign, borderline, and malignant categories. Okay. So the fibroepithelial family of breast lesions is going to include fibroadenoma and phylloides tumor. Essentially anything that's biphasic, which will represent epithelial and stromal components. They almost always present clinically as a breast mass, perhaps a distortion if it's small, like a small fibroadenoma, or maybe even calcifications if it's a fibroadenoma in a postmenopausal patient, in which the stroma oftentimes undergoes dystrophic calcifications. Nevertheless, breast imaging is used to help evaluate the lesion, and some of the things that the radiologist will record is size, margins, and any sort of echogenicity or whatever kind of ultrasound features might help them determine what the cellularity is. Now, to a pathologist, a lot of that kind of goes a little bit out the window when it comes to the echogenicity and some of the other more radiology aspects. I pay a lot of attention to the size, the clinical presentation, just if it's been rapidly growing rapidly, and also what the borders of the lesion are. Now, depending upon that encounter with the radiologist, a core biopsy is used when tissue evaluation is needed, but it's not uncommon for these to also just go to outright excision if the patient desires, or if there's something that's clinically, a core biopsy is not really going to change the management of it. Like a rapidly growing mass sometimes can be just excised at the time of presentation. In general, fibroadenomas don't recur or metastasize, but phylloides tumors can. I'm sure that in the experience and where you are, you may very well have seen a fibroadenoma that has somehow metastasized to the lungs, but this happens in a very, very rare subset of cases. Phylloides tumors can, particularly borderline and malignant cases. And that's why it's our job to classify these lesions as accurately as possible. So first, let's go over the morphology and clinical significance of fibroadenomas and their variants. That would include fibroadenomas with myxoid stroma or fibroadenomas that happen to have some occasional multinucleated giant cells. Then let's go into the morphologic factors important in recognizing phylloides tumors, and then grading of phylloides tumors and why it is important. So we'll start with fibroadenomas. They are by far the most common type of fibroepithelial lesion. I think we have encountered these in our daily practice frequently. They present as painless, mobile masses in patients usually under the age of 30 is when they first happen to present. However, they can present at any age. They're usually solitary lesions, but multiple masses and bilaterality, or meaning that they can affect both breasts, can occur. The occasional patient that might have a germline predisposition to breast fibroadenomas, such as Cowden syndrome, they may present with multiple bilateral fibroadenomas. However, there really isn't anything else that, for instance, these don't have an increased tendency to be phylloides tumors. Imaging, they're circumscribed, hypoechoic. The hypoechoic means that they tend to be solid, and oval mass. Stromal calcifications are common in postmenopausal patients. The risk of future invasive breast carcinoma in a patient who happens to have a fibroadenoma is 1 to 2 times over a 10 to 15 year period. It's basically is the same as proliferative fibrocystic changes. And in the old kind of language, I know that fibroadenomas were listed as a form of proliferative breast disease. Complex fibroadenomas are ones that have superimposed or ones that are combined with sclerosing adenosis may have a slightly higher risk, but there haven't been too many studies done on this. Some patients have a predisposition to particular types of fibroadenomas, ones with myxoid stroma or outright just myxomas of the breast, which would be in Carney syndrome. And then in Cowden syndrome, one of the forms of the P10 tumor hamartoma syndrome, multiple fibroadenomas or fibroadenomatoid nodules can occur. In fact, in patients with Cowden syndrome, they can have the whole spectrum of proliferative fibrocystic changes in the breast affect them. So the general histopathology, here are some of the, at least the terms that we're going to refer to. The stromal epithelial arrangement, peri versus intracannulicular. It doesn't really make that much of a difference which one happens to have them. However, it seems to be that with the fibroadenomas that have a lot of intracannulicular architecture, they can be diagnostically challenging because they can look a little bit like phylloides tumors. In fibroadenomas, we hope to have an even distribution of both components. So there's no areas within it that happens to have an increased stromal presence in which I'm looking around and I can't find as many glands as other aspects of the fibroadenoma or other zones of the fibroadenoma. Areas with small leaf-like projections are acceptable, and we shouldn't be seeing anything like significant periglandular stromal hypercellularity, or essentially any time when the stroma around the glands tends to look extra busy. Borders of the fibroadenoma should be well circumscribed, a pushing growth pattern, meaning that we can draw a nice easy circle around it. And the stromal cellularity should be, well, it ranges sometimes between very hypocellular to areas that look a lot like PASH, and to sometimes mildly increased, particularly in fibroadenomas that present in younger patients. Kind of the old rule of thumb is the younger the patient, the more cellular the stroma can be, and there's a little bit more of an acceptance of increased cellularity so long as the patient is perimenopausal, not perimenopausal, but of reproductive age. Stromal cell morphology, the cells should have normal chromatic nuclei, no hyperchromasia. They can be sometimes plump with an ovoid nucleus to very spindled and PASH-like. Multinucleated giant cells resembling genital fibroblasts can occur. Mitotic figures usually are less than 4 per 10 high-powered fields. And when you're in my, looking at a lot of these breast lesions, you're happy when you can't find any. So less than 1 per 10 high-powered field. And then we shouldn't see anything that looks like heterologous elements, meaning nothing that looks like bone formation or atypical lipoblasts. So let's take a look at some pictures. It wouldn't surprise me if some of you thought that this could represent like nodular pseudoangiomatous stromal hyperplasia or PASH. And sometimes I think that a lot of times they're one and the same thing. But needless to say, whether you call something like this nodular PASH or fibroadenoma, you can see the architecture between the stromal component and the epithelial arrangements can either look like pericannulicular, meaning the stroma grows around the breast lumen, and it kind of reminds me of what we eat a lot around here, which is a burrito in this case, in which each of these little vegetables and meat represent the glands, and then the stroma, or the burrito part, kind of grows around it. In some cases, it can have an intracannulicular growth pattern, and these are the ones that are tricky because sometimes these little areas can look a lot like leaf-like growth. And that seems to remind me of something like this, something that I did a lot when I was growing up, which is the glandular elements seem to be squished by the stromal components, which are kind of pushing everything together. So fibroadenomas with small leaf-like projections are perfectly fine. This is probably a consequence of exaggerated intracannulicular growth, but we're hoping that the leaf-like projections look like little leaves rather than big kind of fronds of a tree, like a maple leaf or something bigger like that. And I'll kind of get to that distinction in just a moment. Cellular fibroadenomas that can have peri and intracannulicular growth at the same time. One's area over here that looks like it's pericannulicular growth and intracannulicular over here. Again, this really doesn't mean that much. It just is helpful to recognize it because sometimes when a tumor or a lesion happens to have a lot of intracanalicular growth, it can look a little bit like a phylloides tumor. And that's something that's going to be challenging for every pathologist looking at something. The borders of a fibroadenoma. So going kind of from low power and then hopefully more into higher power, the borders of a fibroadenoma should be very well defined. Pushing interface relative to adjacent tissue. So that means that it can compress whatever background mammary tissue is there, but it shouldn't creep into it in a permeative or infiltrative pattern. So here we can draw a nice kind of line that represents the limits of the growth of the fibroadenoma. Oftentimes these things are grossly well circumscribed. Now, just because something is grossly well circumscribed doesn't mean that it has to be a fibroadenoma, as a lot of benign phylloides tumors and occasionally malignant phylloides tumors can also have well circumscribed pushing growth. But a fibroadenoma should always have it. Stromal cellularity can range in fibroadenomas, but it should never be hypercellular. So in this case, we have kind of a little bit of a range from relatively hypocellular with sclerotic stroma, and these are the areas that oftentimes will develop dystrophic calcifications, to sometimes a little bit mildly cellular with some periglandular stromal edema making it look like that it's hypercellular. In younger patients, particularly cellular fibroadenomas, we can see an increase in stromal cellularity, but this picture right here should be the limits of what you should expect in a a cellular fibroadenoma. And beyond this, when this stroma becomes hypercellular, it usually also goes along with kind of spacing out of the glands so that the epithelial components, instead of looking like this with a nice even distribution of everything, you'll find little pockets within the fibroepithelial lesion that are just comprised of stroma. And those are the areas that when we start starting to think about a phylloides tumor, or the cues when we start looking at a phylloides tumor. So kind of moving back, the stromal cell morphology to kind of go along with this kind of normal cellular background, the cells should be normal chromatic, meaning that the nuclei are not hyperchromatic, oftentimes with vesicular or see-through kind of chromatin pattern. Ovoid or spindled, sometimes they're a little bit more plump like me, sometimes they're a little bit more spindled, but they should really be identical to normal intralobular stromal cells, or in just normal breast histology, the cells that kind of comprise the stroma or build the kind of stroma around the breast lobules. They should pretty much look the same. The closer the stromal cells are to the glandular component, the more plump I think that they've been. I don't know what the science is behind that, but that seems to be the kind of the common sort of observation to a lot of these things, is that the further out we get, the cells tend to get a little bit more spindled, but they seem to be a little bit more plump. And sometimes this is where you find mitotic figures as well, when they're closer to the glandular element. Rare cases of fibroadenomas may have multinucleated stromal giant cells. In a way, this resembles the multinucleated fibroblasts in the periareolar or even the genital region, like the vulvovaginal area. And what these look like are enlarged cells that have multinucleated giant cells. And they may appear a little bit hyperchromatic, but probably that's because there's a lot of them packed closer together and it just gives our eyes the impression that way. But there really shouldn't be any cytologic atypia to the individual nucleus, meaning nothing that looks pleomorphic. We shouldn't be seeing mitotic figures. In general, they look like a multinucleated giant cell, only in this case, it happens to be within the stroma. And there's no clinical significance to this. It's just part of a normal variant to a fibroadenoma. Now, immunohistochemistry, when it comes to fibroepithelial lesions in general, is not very helpful. It tends to only be helpful when you're trying to characterize some sort of intraductal hyperplasia, as can happen in a lot of these fibroadenomas. Some fibroadenomas have a lot of usual ductal hyperplasia. Sometimes it can be florid, and I found that at least in our practice, or at least in our experience, immunohistochemistry is used to kind of more characterize those areas rather than the stromal cells in and themselves. But nevertheless, spindle cells will be positive for CD34 and estrogen receptor, and they'll be negatives for keratin and as well as nuclear beta-catenin. Molecular genetics can be done on fibroadenomas, but in general, it's not very helpful. People have found MED12 exon 2 mutations, either nucleolide insertions or deletions, but these really don't have any sort of clinical significance, and potentially the only kind of help they would be is in trying to determine if something is a metaplastic carcinoma versus something like a malignant phylloides tumor, in which, in a lot of cases, that there might be treatment differences between the two of them. But when it comes to just characterizing fibroadenomas, or the majority of fibroadenomas and even low-grade phylloides tumors, molecular genetics is not too helpful. Variants, we kind of looked at a few variants already, or ones that in which they're fibroadenomas with the expected behavior of fibroadenomas, but they just have a different morphologic appearance to them. And that includes complex fibroadenomas, ones with stromal giant cells, the tubular adenoma variant, which is a fibroadenoma in which it's hard to see, for one, the stromal kind of component, and just looks like an area that resembles nodular adenosis. So let's take a look at some of these variant morphologies. So here we have a fibroadenoma. It's well circumscribed. It has a nice pushing interface between background normal breast and the fibroadenoma itself, but the epithelial elements are particularly busy. And in this case, it's a lot of sclerosing adenosis in areas that look like fibrocystic changes. Now, sometimes when this occurs, most of my attention is not so much, is this a fibroadenoma or a phylloides tumor, but just being reassured that the epithelial elements don't represent something else, like atypical hyperplasia, or even the rare case of an invasive carcinoma that can kind of grow in a fibroadenoma. So here we have the normal fibroadenoma arrangement, and just a little bit busier with this kind of more sclerosing adenosis element superimposed or just right within the fibroadenoma. In some cases, the stroma looks a lot like PASH, and this is a picture from that first case that I shared. It has that characteristic cracked pseudovascular architecture, in which in my young days I thought, well, why aren't these things blood vessels? But they don't have any red blood cells in them, although they certainly look like it. And this is a pretty normal phenomenon that happens in breast biopsies, sometimes up to 20% of cases in leading from patients with architectural distortion. But in some cases of fibroadenoma, the stroma looks exactly like PASH. And in some cases, we either refer to it as a fibroadenoma or fibroadenoma with PASH-like stroma, but it doesn't really matter, and it certainly doesn't matter to the radiologist so long as it accounts for the lesion that's being biopsied. Here we go again with the cracked pseudovascular spaces. Some areas look a little bit more plump, but that's something that can happen in PASH. And then there are cases in which you have complex fibroadenoma as well as ones with PASH-like stroma within the same kind of lesion. Here we have sclerosing adenosis, and then ones that have this sort of cracked pseudovascular spindle cell component associated with it. The tubular adenoma variant, prominent but lobular proliferation of breast acini that happens to just form a mass for whatever reason. Sometimes these are in biopsies, these can be called nodular adenosis as well as tubular adenomas, but again, this really doesn't have any clinical significance so long as the radiologist is confident that what you're seeing under the microscope explains what they are seeing in breast imaging. So we can see that in these tubular adenomas, they closely resemble adenosis at high power. However, these areas are going to all have their myoepithelial markers. And in this case, it would be very, very strange for a phylloides tumor to have this dense of an epithelial or glandular component. In some cases, fibroadenomas might have a more myxoid stroma. This doesn't have any clinical significance, and it's very, very rare for them to be associated with something like Carney syndrome. But it's the same thing. A lot of times these are hypocellular. It does not look like a particular matrix. It could just be some basophilic extracellular material. But in this case, hypocellular kind of background and nothing that looks in the way of cytologic atypia. And then juvenile fibroadenomas, they usually present in adolescence, and they tend to present as fast-growing masses. They have oftentimes a well-represented epithelial component in which you wouldn't really be thinking about a phylloides tumor by virtue of the number of glands that are in the background. So there's no areas in which the stromal element is kind of more than the epithelial element. They tend to have a pericannulicular arrangement rather than the intracannulicular one, so no leaf-like growth in these. Intraductal hyperplasia can resemble that seen in patients with gynecomastia, and specifically this sort of little micropapillary tufting that occurs. The stroma in these can be a little cellular, and there can be mitotic figures, but they should be less than 4 per 10 high-powered fields. Oops, I'll go back to that. So plump stromal fibroblasts, no atypia, normal chromatic, gynecomastic kind of intraductal hyperplasia. And in this field, we don't see mitotic figures, but they can be there, but they really shouldn't be very many of them, less than 4 per 10 high-powered fields. Okay, so you can get the full spectrum of intraductal hyperplasia in fibroadenomas, and that includes ADH, or atypical ductal hyperplasia, florid usual ductal hyperplasia, lobular neoplasia, and outright ductal carcinoma in situ. It is kind of our experience, and that noted by a lot of individuals who have seen a bunch of these tumors, that of all the atypical hyperplasias, it tends to be lobular. And for that reason, once I have determined that a fibroadenoma is that, and it's a core biopsy, and I'm not worried about a phylloides tumor, the next thing I look for is just making sure that there's no sneaky atypical lobular hyperplasia going along in the epithelial elements. Invasive carcinoma arising within a fibroadenoma is rare, but it has been observed. And the epithelial component in those tends to deviate quite a bit from the lobulated architecture in a normal fibroadenoma. So here's an example of a fibroadenoma with very florid usual ductal hyperplasia to the point where it's expanding kind of the stromal component. Usually in a lot of these benign intraductal hyperplasias, like usual ductal hyperplasia, they tend to be almost seen in a lot of fibroadenomas in younger patients. And the tendency is for them not to necessarily splay apart or expand the epithelial component, but rather to kind of be squished together. It tends to be in the usual ductal, or I beg your pardon, the atypical ductal hyperplasia in DCIS, in which the expansion by those epithelial cells tends to kind of be rigid, in which the stroma component sort of gets pushed away by the epithelial growth. And we'll see that in just a moment. But there are examples of usual ductal hyperplasia, florid examples, in which the epithelial component is very prominent and tends to push apart or kind of expand the stromal zones. Here we have this nice syncytial growth pattern, meaning it's very difficult for me to tell where one cell ends and one cell begins. It looks like just one big cell with lots of pink cytoplasm. Slit-like spaces, no true cribriform or cookie cutter or really round punched out spaces. And there is a little bit of cell-to-cell heterogeneity, not to the point of something like ductal carcinoma in situ, but where this cell looks a little bit different than this one, which looks a little bit different from this one. So typical features of usual ductal hyperplasia. But the one that I look for, because I think that lobular neoplasia is very sneaky, it's very hard to see, is fibroadenomas with LCIS. And you would be looking for the same things, an expansile, in this case, one that's pushing out the epithelial component of disheesive epithelial cells, meaning the cells look like they're loose. Like if they were in a jar and you were to upend the jar, they would all come out. They would all come rushing out and fall on the table, which is different than ductal epithelial proliferations like usual ductal hyperplasia and DCIS. So here, a lot of white spaces in between them. You get a feeling that they're kind of loose. A lot of eccentrically placed nuclei that kind of has a like plasmacytoid appearance. And then very monotonous cytology, like almost every cell looks identical. And then finally, ductal carcinoma in situ involving a fibroadenoma. In this case, it also is expansile, so it's pushing out these fronds a little bit as if they're saying, I am here and I am staying, whereas usual ductal hyperplasias and the other one tend to get squished together a lot more. But needless to say, it's expansile. We can see micropapillary tufts, coarse intraductal calcifications, a little bit of comedonecrosis, and in this case, cells that have a lot of nuclear atypia in the form of hyperchromasia, pleomorphism, irregular nuclear contours, and all the things that we have come to know with ductal carcinoma in situ, in this case, which would be high grade. So as a summary, Fibroadenomas, these are benign regardless of the type of variants, and the things that we like to see, and you have probably seen much more in your practice, circumscribed borders, a very easy to find glandular component that can either be pericannulicular or intracannulicular, but so long as you can see it, that's good news. Variable cellularity, but there's no periglandular hypercellularity, and it really shouldn't be that cellular. Even in very cellular fibroadenomas or juvenile fibroadenomas. Most of the cells should be non-atypical, normal chromatic. Multinucleated giant cells can happen, but they're particularly rare, and we shouldn't be seeing a lot of mitotic figures. In a lot of cases, we don't even count because we're so used to these kind of elements in daily practice. But if we forced ourselves to count for a change, or at least I would have to say that for me, they tend to be less than 4, oftentimes less than 2 per 10 high-powered fields. And then we shouldn't be seeing any malignant heterologous elements. So the variants can complicate core biopsy diagnosis, and when you have superimposed intraductal hyperplasia, that tends to be the things that complicate these things much more than is it a phylloides tumor or not. Okay, so let's take a look at a recent case when we start getting into some of these more complex or weirder looking fibroepithelial tumors. So this is one that I had a few months ago. This was from a 50-year-old patient. It was a 5-centimeter circumscribed breast mass. It was growing, so it was immediately excised. This one did not go through a core biopsy. So here's what it looks like off the get-go. It's not particularly cellular. There is some intracannulicular and almost leaf-like kind of protrusions, but otherwise this doesn't look so bad. It's pretty hypocellular, nothing that looks like periglandular hypercellularity, no malignant elements. But it's 5 centimeters, so we want to make sure that we sample this appropriately. Okay, well, more pericannulicular growth, little intracannulicular, but whatever, this does not look too bad. And probably a lot of this difference between the stroma here and the stroma in other areas is just that there's edema there rather than true periglandular hypercellularity. But then we take a few more sections and we get this kind of stuff, in which it's not so long as at first we had some intracannulicular growth, which meant that these little protrusions, they looked like little petals on a flower, but now these things are starting to look like leaves on a tree. So a little bit more pronounced, deep-lying epithelial clefts. And here's what the stroma looks like. Well, it's not too bad. In other words, to somebody like me, is that most of the cells are normal chromatic, tiny little nucleoli, not a lot of pleomorphism, but there are easy to find mitotic figures in here, and it is pretty cellular. So these are the cases that are really tough. And you probably would get, if you were to ask 10 pathologists, do you think this is a fibroadenoma or a phylloides tumor, you would get 11 different opinions. And sometimes I am not sure about what that diagnosis is. Well, you take more areas and we start seeing kind of spots like this in which the stroma is now expanded. This is something that has broken kind of the pattern in what we've seen, in which it's kind of hypercellular, it has splayed apart these epithelial components, it's hyperchromatic, and there's easy to find mitotic figures, and there's certainly a cytologic atypia here. So these are the cases that we're going to go through and try to determine, well, where would we be if we wanted to call it a phylloides tumor? Would this be something that's benign, borderline, or malignant? So phylloides tumors, I think that it's been pointed out for a very long time that they represent a morphologic continuum ranging from very, very bland and benign to obviously malignant, to the point where we're not even sure if it's a phylloides tumor. We would be thinking the possibility of a metaplastic carcinoma, which 9 times out of 10 is probably more common. So the overlapping features make the diagnosis of some fibroepithelial lesions very challenging, no matter how much experience you have. Diagnostic standards only exist at the ends of the spectrum, meaning it's easy to tell the difference between a benign phylloides tumor and malignant ones. But that gray area, as Chevy Chase has said in the past, that's a very, very broad spot and sometimes can be about as dark as charcoal. So studies on these outcomes of these gray area cases are lacking. These are the ones that usually aren't talked about in studies because nobody can agree on what the diagnosis is. And sometimes I disagree with myself. So what are our morphologic cutoffs between a fibroadenoma and phylloides tumors? And then once we know it's a phylloides tumor, how do we grade them and what is important? So first is just a brief introduction. Phylloides tumors are fibroepithelial lesions with an expanded and hypercellular stromal component. So something deviates from the background of a fibroadenoma. They're pretty rare, 1% of all primary breast tumors and less than 5% of all fibroepithelial lesions, at least in Western population. They present as solitary, painless, mobile masses, and I'd be willing to bet that most of them are circumscribed. The mean age is 40 to 50 years. The average size is about 4 to 5 centimeters. The rule of thumb that I learned when I was in training is anything over 3 centimeters, Andy, make sure that you sample it just in case there are areas that look like a phylloides tumor in the background. Imaging, the findings can be very similar to a fibroadenoma. They can't be used to reliably distinguish a phylloides tumor from a fibroadenoma. So a lot of times the radiologist is going to be able to notice a mass, and maybe they'll say, well, it's about 3 centimeters or 11 centimeters, in which case 11 centimeters we would have our work cut out for us. But on top of that, the echogenicity, any of the other stuff that our radiologists use are not very helpful in the characterization. The grading of these reflects the recurrence risk and metastatic potential. Benign and borderlines have a recurrence risk, at least in the literature. Borderline tumors, most certainly. Benign tumors probably have a behavior that's more like fibroadenomas than borderline tumors. So therefore, on the clinical grounds, it's just important to make sure that if you call something a benign phylloides tumor, that it's completely excised. Borderline tumors may need a little bit more of a margin to them. Malignant tumors have a recurrence risk as well as metastatic potential. But I'm sure that in all of our experiences, we have come across very bland-looking fibroepithelial tumors which have recurred or in rare cases have metastasized to the lungs. And I'm sure that some of our pulmonary pathologists or some of the pulmonary pathologists that colleagues of yours have seen those kinds of cases, which are terrifying to me. So things to assess, things to kind of be aware of when we're looking at a fibroepithelial lesion. Stromal expansion and cellularity. Is it similar to a fibroadenoma or is it hypercellular? What are the borders? Are they well circumscribed or are they kind of infiltrative or not a perfect circle? And we'll take a look at some examples. Stromal cell atypia, does it look pretty bland or are these really ugly looking cells? Variety of cutoffs for mitotic figures. The rule of thumb again is the more atypia that is there usually correlates with increased mitotic figures. Heterologous elements like liposarcoma and osteosarcoma oftentimes makes, although we're not happy to see it, it makes our jobs a lot easier because it won't ever be a benign phylloides tumor or a fibroadenoma if we are to see some of these malignant elements. And then stromal overgrowth, which is the absence of an epithelial component or any kind of glands in a 4x low power field. So let's take a look at some morphologic cues. All right, so this is an example of a benign phylloides tumor in which there is a stromal expansion. Now this doesn't come along with a lot of stromal hypercellularity, but in this case, it's kind of forming these big leaves. So in this case, a big maple leaf from kind of our area in Cleveland versus the tiny little petals that one would see on a flower for these more just intracanalicular growth. So again, really, this is a 2x field, really, really big, deep-lined epithelial clefts with these big kind of leaf-like growth. That's stuff that we want to see in a benign phylloides tumor. But when it's pretty small, those are the ones that we tend to let go and just say that's intracanalicular growth in a fibroadenoma. Expanded stromal component, again, with broad leaf-like deep epithelial line clefts. So to say that there's leaf-like growth oftentimes means that there's these big things that give it that leaf-like architecture, which is these clefts that go along with it. Sometimes these things can look a little bit like the clefts one sees in a smooth muscle tumor of the uterus. So along with the expanded stromal component, although we don't have a well-developed leaf here, something had to have happened in the stromal component in order to make this such a big, deep-lined cleft. So at some point, this thing developed more of a stromal kind of proliferation relative to the glands. Expanded stromal component. So there's no leaf-like areas in this example, but the glands are less concentrated in the middle of these otherwise more normal of these zones, and there's more stromal cellularity. So something is happening here in which the stromal component is a little bit off kilter or kind of growing faster than the epithelial component here. There can be variability in growth patterns within a phylloides tumor. So if we were just to see a core biopsy from an area like this, maybe we would say some leaf-like areas, but otherwise it doesn't look too bad. Normal cell, but actually relatively hypocellular. But this, it being a big tumor, if it were sampled right here, well, that's a completely different, in which we are not seeing anything that looks like an epithelial element. So as with any kind of lesion in the breast, sampling is very important with these tumors, but also a lot of it depends on just the luck of sampling as well. Stromal cellularity, sometimes with the expansion, there can be sort of more phylloides tumors with more hypocellular stroma to more mildly cellular, to kind of differences in the in variability in cellularity between hypo, mildly cellular, and moderately cellular. These can have a lot of heterogeneity to them. Kind of just different, kind of going from more moderately cellular stroma, more so at least than a typical cellular fibroadenoma, and also there's a little bit of that periglandular stromal hypercellularity or condensation, as some people will say. Very high nuclear density in this example, looks almost like a high-grade sarcoma. And then there are some cases in which, although for most of phylloides tumors, increases in cellularity and atypia tends to mean a decrease in the epithelial component, but it doesn't always work out that way. And there are some cases of a malignant phylloides tumor with these terrible-looking epithelial cells that still have a recognizable epithelial component to them. So that's why there's always some variability in some of these phylloides tumors, and it tends to be when we're grading these things like a bit of a seesaw. Like some things that make us think, is it more on the malignant side? Is it more on the benign side? And then that kind of very broad gray area of borderline. Borders for a phylloides tumor. So we looked at the cellularity, we looked at the architecture. Is it intracanalicular? Does it have big leaves, small leaves? And some of the cellularity of the stroma. So now let's take a look at the borders. So in a lot of particularly benign phylloides tumors, there's a sharp interface between the phylloides tumor and the background normal breast. You can almost draw a perfectly round look, or a perfectly straight line between the two. But sometimes there are infiltrated borders, and whether this is some sort of infiltration that comes from kind of periglandular stroma kind of creeping into the background breast, or if it's just this kind of more nodular kind of infiltrated pattern, I'm not 100% sure what it is, but I can tell that this has lost circumscription to it, in which it's no longer a nice sharp interface between this fibroepithelial lesion and the background breast, but we kind of have this area that's pooching out and seems to be within the stroma. This is kind of another example of it, and this is a very common, this is probably the more common way of, or common morphology of infiltrative borders in phylloides tumors than outright just destructive growth, is you get this kind of loss of circumscription in which the cellularity seems to creep around these glands and make them look different. So instead of the destructive growth pattern that we're so used to in invasive carcinoma, in phylloides tumors, it's a loss of circumscription that sometimes can be nodular, sometimes can be permeative, but one way or the other, it no longer forms a nice pushing, even growth pattern between the fibroepithelial lesion and the benign breast stroma in the background. Here we go is another example in which we have a lot of an epithelial element in here, in which I might not be thinking about a phylloides tumor. However, once it starts forming this infiltrative growth pattern, it really makes us consider the possibility that we're no longer dealing with fibroadenoma, but we're dealing with a phylloides tumor. In this case, has this moth-eaten, almost permeated growth pattern, not destructive, but it's no longer a nice, even circumscribed or pushing interface between the fibroepithelial lesion and the background mammary tissue. Here's another example of kind of something that is actually from the case that we just saw, in which this kind of more nodular growth pattern has now led to a malignant stromal component that looks a lot like just a sarcoma within fibroadipose tissue. So stromal cell atypia. Benign phylloides tumors oftentimes have no or very mild or no cytologic atypia. And again, that would be normal chromatic nuclei, spindled ovoid morphology, no nuclear enlargement. But once we start seeing this kind of pattern in which the nuclei are normal chromatic, but clearly are much more cellular and there's more of a nuclear enlargement, then we start getting into mild sort of cytologic atypia. They still look spindled and ovoid, but they're big and there's a lot of them. Moderate cytologic atypia in this case would be nuclear hyperchromasia. There is some pleomorphism, but otherwise they have smooth nuclear contours. Again, along with this increase in cytologic atypia, there tends to be an increase in cellularity. And with an increase in cellularity, there usually is an increase in mitotic figures. I mean, it had to get hypercellular somehow. Mitoses would be the easiest way to go about doing that. Then there are cases that have severe cytologic atypia, and this tends to be something that we see in malignant phylloides tumors. And why that diagnosis can be very easy. We know that it's something malignant, but also very difficult because sometimes these things can be very difficult to separate from metaplastic carcinoma. So conspicuous pleomorphism, it's really easy to see these cells. Irregular nuclear membranes, hyperchromatic, enormous pleomorphic nuclei. There are some cases like this one. This one was from a malignant phylloides tumors in which I wouldn't even know that this is a sarcoma. This to me almost looks like adrenal cortical carcinoma. But this was right in the middle of a fibroepithelial lesion. And I guess that's just the form of malignant, of kind of the malignant stromal component, but you can see some really strange things in the background here. Then let's get to stromal overgrowth, and this is one of the important ones that we have to pay attention to, and that's no epithelial elements in a 4X field. It makes the diagnosis of a phylloides tumor a lot easier, but we have to remember that if we just see something that looks like stromal overgrowth but does not have any kind of epithelial element in it, meaning it just looks like a bunch of spindle cells, we have to make sure that we're not dealing with a different kind of tumor. And sometimes spindle cell lesions of the breast that are not phylloides tumors, such as metastatic melanoma, can exist. Finally, heterologous elements. In this case, we have liposarcoma. Liposarcoma doesn't automatically make it into a malignant phylloides tumor, but it certainly makes it into the borderline category. And I think you would have a lot of pathologists who are uncomfortable calling a phylloides tumor benign when there is kind of a malignant liposarcoma. But if it's the case of rhabdomyosarcoma or osteosarcoma, it automatically qualifies it for a malignant phylloides tumor, no matter how bland the background looks like. So ancillary studies in phylloides tumors, overall, I do not think are particularly helpful because there is a lot of overlap in the immunophenotype or the immunohistochemical expression pattern between phylloides tumors and metaplastic carcinoma. And I oftentimes don't even do them when it comes to either excision specimens and especially on core biopsies, because malignant phylloides tumors can express keratins and P63. They can even express high molecular weight keratins like CK56. But in general, your benign and borderline phylloides tumor are CD34 positive. They will be cytokeratin and P63 negative. Malignant phylloides tumors, you can see a lot of crazy things. Sometimes they're CD34 negative, sometimes they're keratin positive. And the only true way to know you're dealing with a malignant phylloides tumor is if you see something that looks like a phylloides tumor or a fibroepithelial lesion in the background. So here's a malignant phylloides tumor in which if we had just gotten a biopsy right here, I would have no idea what it is. But because we have something fibroepithelial in the background, we can say, all right, this has to have been from a malignant phylloides tumor. There are very rare case reports of collisions between metaplastic carcinoma and malignant phylloides tumors, but I'd also be willing to bet you that experienced pathologists out there would say, Andy, no, it's either one or the other. And I remember that experience when I was going through training. So here in this example, in which we know it's a malignant phylloid, this is a fibroepithelial lesion because it has this fibroepithelial component to it. If we were to do P63 and keratins, this one was positive for both. And had the biopsy just been done on an area like this, back when I was in training, this would have been called a metaplastic carcinoma, although we are looking right at a malignant phylloides tumor. So grading of these. The grading criteria, the morphologic cues used to determine them, we kind of went over. Stromal cellularity, cytologic atypia, borders, other morphologic variables that have been used but are not considered orthodox ways of grading for phylloides tumors, coagular necrosis, lymphovascular invasion, which is extremely rare, and the size of the tumor. But Using grading dependent on the WHO criteria, or the ones that we see in the Blue Book, they will have this general table which shows what is tolerable in a benign, borderline, and malignant example. This grading system is imperfect. There's a lot of inter-observer variability, meaning that you have pathologists disagree, which is something that you've probably seen in your practice. There are diagnostic gaps, particularly when they come to borderline cases. But in general, something that the WHO advises is that only make a diagnosis of a malignant phylloides tumor when you can check all or most of these boxes. Meaning you see increased cellularity, it's severely atypical, lots of mitotic figures, there is stromal overgrowth, infiltrated borders, heterologous elements, absolutely. When you can check most of those boxes, then make a diagnosis of a malignant phylloides tumor. Otherwise, consider the possibility of a borderline. But when it comes to management of borderline and malignant phylloides tumors, they're pretty similar. Make sure that you have the entire lesion out, usually with a 1 centimeter margin around them. Benign phylloides tumors, ones that at least everybody can agree that they're benign phylloides tumors, the behavior tends to be more similar to a fibroadenoma, meaning make sure that the whole thing is excised, but you don't need to have wide margins. So which variables are more important? Grading suffers from a lot of inter-observer variability, and then this kind of grading and the significance of surgical margin status is always going to come up in our practice. And as a pathologist, my mentor, Jeff Myers at the University of Michigan, would say grading is a dirty business, and so is the rest of pathology sometimes. So the grading and risk stratification, it kind of gets to the badness in the stromal component, ranging from something that looks like a fibroadenoma to kind of some variability when we're going into benign phylloides tumors to borderline and to malignant. So really the morphology of the stromal component defines the risk of recurrence and metastasis, and we all know that, and that's what we're paying the most attention to when we see a funny-looking fibroepithelial lesion. So let's take a look at this case. So the first thing I have to ask myself is, probably at low power we can tell that this is not something that is very good. It is very cellular. You can tell that there's pleomorphism. We know that it's probably malignant, but I don't even know what this thing is. It's infiltrative, it's cellular, there's overgrowth, there's pleomorphism. It could be a phylloides tumor, but it could also be something else that's malignant. So after a lot of sectioning of this very large tumor, there was only a focal residual fibroepithelial component that's there, which makes me feel confident that this represents a malignant phylloides tumor rather than a metaplastic carcinoma. And in my experience, that is the major differential diagnosis when it comes to a malignant phylloides tumor is it a metaplastic carcinoma? Because we all know that metaplastic carcinomas are about 8 to 9 times out of 10 more common than a malignant phylloides tumor. Here was the stromal component. So it's kind of like that case I just showed you in which I have no clue what this is. It looks like there's a lot of microvesicles in here and tremendous cytologic atypia. So this one, because of that fibroepithelial component, I felt confident calling it a malignant phylloides tumor. But this is one in which immunohistochemistry is not going to help us out very much. Here's another example. We have a fibroepithelial architecture, so we can tell it's a fibroepithelial lesion, but it does have some areas of increased cellularity. It's infiltrative. It doesn't have a very sharp interface between the background breast tissue and the fibroepithelial lesion. It has this kind of funny loss of circumscription to it, that nodular infiltrative growth that we've seen. It's got some expanded stroma, meaning it's very prominent and it's kind of pushing out the epithelial elements, but we don't see stromal overgrowth. And there is severe cytologic atypia. There's conspicuous or easy to find mitotic figures to the point where it's not necessary counting them. You know that there's going to be a lot. And there's also, in this case, heterologous liposarcomatous differentiation. So heterologous elements, other than liposarcoma, automatically guarantee a diagnosis of malignant phylloides tumor. But since this is just liposarcoma, it doesn't push me all the way into that category. Now, because I can't check every single box, I know I'm not going to call it a benign phylloides tumor, but I'm right into borderline phylloides tumor territory. I can check some, but not all the boxes. And this just lets the clinicians know that this thing has recurrence potential, and they may want to achieve a wider margin than usual. Fibroepithelial lesions on core biopsy, this will probably be the last thing I kind of get to. We have a conservative approach here at Cleveland Clinic, meaning if there's something that deviates from an easy to see or easy to diagnose fibroadenoma, we tend to flag that as a fibroepithelial lesion and recommend clinical radiographic correlation. What we usually do is probably the exact same as what you do. We don't have anything that's special about it. We share the case with colleagues, discuss the case with the radiologist, and if there's something that still doesn't look right, or if it's a rapidly growing mass, or we can't decide if it's a fibroadenoma or phylloides tumor, we will say cellular fibroepithelial lesion, please see comment, and that comment is usually we shared it with a number of colleagues, and the differential diagnosis includes a cellular fibroadenoma versus a benign, or versus, I beg your pardon, a phylloides tumor. So here's an example. An ultrasound-guided core biopsy. This is from a 28-year-old woman with a rapidly growing breast mass. A lot of this looks like fibroadenoma. Just a little bit more cellular, a little bit more prominent kind of intracanalicular growth. Here's kind of the degree of stromal cellularity. There are some mitotic figures, but there's nothing that looks atypical. But it deviated, to our group at least, and we made the diagnosis of a cellular fibroepithelial lesion, and then in a comment saying that our differential diagnosis include a cellular fibroadenoma and a benign phylloides tumor. And on excision, this was a cellular fibroadenoma. So the take-home points when you encounter a fibroepithelial lesion, ask yourself, does the stromal component look prominent or expanded? Are the stromal cells atypical? How hard is it to find, or how easy is it to find mitotic figures? Is there anything that looks like it's lost circumscription or might be even outright infiltrative? And are there any heterologous elements? And these are the things that we think about every time we see a funny-looking fibroepithelial neoplasm. Here are some helpful papers. I think in the slide session, we will have some cases that we'll take a look at that kind of practices this differential diagnosis. But does anybody have any questions?
Okay, thank you, Dr. Erndu, for the comprehensive overview. If anyone have any questions, please feel free to use the microphone or write your questions on the paper and send it to us or our staff.
Okay, thank you, Andrew. I'm Dr. Supinda from Konkan University. Thank you very much
Hello.
for your wonderful lecture.
I wish I could meet you in person, yeah.
Yeah, nice to meet you even online. We are happy to join with your lecture. And I have one question. That's the last case that you shown us about fibroepithelial lesion. We have problem when we sign out the case like this word. The clinician who accept our report, they do not happy. They want to know what is. We want us to judge is phylloides tumor or fibroadenoma. What do you suggest us if we have this issue?
Well, I understand that completely. I've been in the same situation in which sometimes I feel like the expression I use here is the radiologist is holding a gun to my head, wanting me to decide if it's a fibroadenoma or a phylloides tumor. Well, there's a couple different kind of aspects of that. In one case, I remember just showing we have like a radiology pathology conference here. And for one of those sessions, I just showed them, here are kind of core biopsies of patients with fibroadenomas and phylloides tumors. And then I showed them a few cases in which I said, we called this cellular fibroepithelial lesion because we couldn't tell if this was a phylloides tumor or not. And then I would show them, well, here's the excision of some of these in which it went, okay, it's a fibroadenoma, as most of these are probably fibroadenomas, but then percentage of cases in which it went into something that was obviously malignant and just saying this was sampling. So I tend to be more of a shower than a teller. And in those kinds of, that strategy, I just said, just take a look at this. We're both on the side of diagnostic medicine in which we're both looking at things and trying to come up with a differential or and just going, we can't tell in these cases. And there's no genetic test, there's no immunohistochemistry, there's nothing that can be used. We just don't want the wrong thing to happen to the patient. So a lot of times I've shown them those. The other way that we've gotten around it is I say, hey, I shared this with a number of colleagues that have a lot of experience. None of us are sure that this is either a fibroadenoma or phylloides tumor. That's the best that we can do. And there really isn't anything else that we can do. So I have a feeling that probably a lot of the things that I'm saying that you have done already, I think that probably the one thing that definitely has helped is if you're able to share the case with them and say, hey, here's what we're seeing under the microscope, or just get a lot of people behind that and say, hey, it's not just me who is having trouble with this, but it's the rest of our group. I don't know, is that helpful? Do you have any suggestions that might be helpful? Because I think that this is one of those problems that tends to be there. I'm grateful that our group has a lot of radiologists who kind of, once I think that we've given that time to kind of explain those things to them, they have welcomed that information, but it hasn't always been easy.
Okay, thank you. We have the word to talk with our clinician later. Okay, thank you.
Everybody, yeah, I know. Sometimes it's a good conversation. Sometimes you wish that, it could have gone in a different direction, but that's the way it goes for some of these things. It's impossible to tell in some cases.
Thank you, Dr. Andrew. And next is a question from resident from Khon Kaen University. In corneal biopsy of breast, what is clue to distinguish between fibroadenoma and fibroadenomatoid change?
I think probably the big clue to determine between the two is, am I looking at one, if you're looking at the biopsy or an excision, or I guess let's just say it's a core biopsy, am I able to see, does it look like one lesion, like one big kind of mass, or does it look like a bunch of mini fibroadenomas that are kind of all part of one, maybe they all are part of one bigger mass? But that's kind of is what goes through my head is it one big thing, like it seems like one process in which I'll feel comfortable calling it a fibroadenoma, but if it looks like a bunch of mini fibroadenomas, I'll call that fibroadenomatoid change or fibroadenomatoid nodules. And the good news is that in most cases, our radiologists don't care. Not to say that that they are more primitive than we are. I certainly am not saying that. They have a lot more cooler toys than we do. But as long as there's something that to them accounts for a mass, maybe it's a bunch of little fibroadenomas that look like one big one that they're seeing, or who knows, they'll be content with the diagnosis. And I found that sometimes in architectural distortion, instead of it getting a core biopsy, they tend not to look like fibroadenomas, they tend to look like fibroadenomatoid change. So I don't know if that's helpful, but I think so long as it's communicated to the radiologist that it accounts for the mass or the distortion, then you're okay. But a bunch of little fibroadenomas, I'll call it fibroadenomatoid change. If it's one lesion, then I'll just say fibroadenoma. But there's really no science behind that.
Okay, I have a question related to the overgrowth stroma. It's defined as the absence of glandular components at the 40x field. So how we define this criteria on digital slide? Because I know so far the 40x field on digital slide is quite different to the 40x on a manual microscope.
That's a great question. I think when they put in the stromal overgrowth as like in a 4x field, I think for a lot of people, they can say that that's a low power field as well. So even if there's individual variability between my low power 4x field, 40x once you include the eyepiece, that there might be differences between like my scope and your scope. If it's in cases in which it seems like it's a low power field and that you can't find anything there, that it's a guideline and that you can still call it stromal overgrowth. But if it's, usually in stromal overgrowth, but I know that there are examples in which it doesn't work out this way, that it tends to be like pretty prominent and you oftentimes say, hey, there is stromal overgrowth there. I can see it from a 2x field or a 20x, overall objective. So there are differences between the eyepiece, but that's probably not that big of a difference than we think that it is. So long as it looks like that there's no epithelial elements at a low power field, 4x being the kind of the minimum low power field for that, then it's okay. So, differences between other objectives probably doesn't mean that much. Once you see it if you're comfortable seeing it in your, if you don't see anything in your like 40x kind of field, then go ahead and call it stromal overgrowth.
Okay, Okay, thank you. And another question is, do you have like a reporting system for the breast lesions on core biopsy? Kind of like a little bit similar to beta system on cytology or something like that?
Oh, I see what you're saying. So just to make sure, that's a great question. Will we say something along the lines of atypical, suspicious, or malignant? Is like something like that, or?
Yep, it kind of like the
Okay.
classification like unsatisfactory, benign, atypical, suspicious, and malignancies. Yeah.
Gotcha. We tend not to use like a Bethesda or like a cytopathology kind of method of doing that. For instance, like if we have kind of like a straightforward diagnosis on a core biopsy of a fibroadenoma, then a lot of these being cellular fibroepithelial lesions, I don't know if it's a practice in your group, but it's really hard to make a definitive diagnosis of a benign phylloides tumor, or even sometimes a borderline phylloides tumor on core biopsy, just because you have no idea what the rest of it is going to be, and it's a pretty major diagnostic call in which you could get big margins on a case. But nevertheless, what we tend not to use something that goes with unsatisfactory, benign, atypical. However, if your clinical team is practiced in using that and understands kind of the implications of saying atypical fibroepithelial lesion, and that recommends them to go get an excision, then I think that that's a great system for it, and I certainly would use that. Just, I think our radiologists and our clinicians, we would have to, there would probably be quite a bit of training between the two of us to know what we meant by atypical or suspicious and that sort of thing. And we probably, if we had to do that, would have to come up with, well, how many of the atypical cases become phylloides tumors, how many of them become malignant? So barring that, we tend to use something along the lines of fibroadenoma, cellular fibroepithelial lesion, and then, even if in the cellular fibroepithelial lesion, if we can't see anything that even looks like the epithelial component, then we will say atypical spindle cell lesion or something along those lines. So we don't have something, but I think that each of those little categories will, other than saying that it's a fibroadenoma, will kind of trigger the clinician to recommend an excision in that case. But I think that, using the, benign, atypical, suspicious, if that is kind of understood by your clinical team, then I think that would be a very reasonable system to use, and one that has much more uniformity to it.
Thank you. So for another tumor with the borderline phylloid, but if the tumor presents maybe another 2 or 3 criteria of malignancies, how would you report in this case?
So let's say that we have what we know is at least a borderline tumor, but there's also 2 or 3 more things that make us worried that it's a malignant phylloides tumor. What I would probably still say is, if I can't get to like a confident diagnosis of malignant phylloides tumors, I will still say a borderline phylloides tumor with stromal overgrowth, or borderline phylloides tumor, with liposarcomatous differentiation. And that will indicate to the clinical team that there is recurrence risk with this, and that there is stromal overgrowth and these other things. However, I can't make this into a malignant phylloides tumor. The clinical impact of something like that is probably pretty minimal, because in either case, whether it's a benign or whether it's a borderline or malignant phylloides tumor, those patients will be monitored for recurrence. And at least at our institution, a lot of times they will also do at least imaging of the lung to make sure that and of the axilla to make sure that there's no metastases.
Thank you.
So we just might say borderline with, but not getting to a definitive diagnosis of a malignant phylloides tumor.
Okay, thank you very much. Thank you.
You're welcome.
Hello, I have last year I have a case from right chest wall of the woman who has a prior history of malignant phylloides tumors. And at that time, I thought it's recurrent of the malignant phylloides tumors. But after extremely gross examinations and get the tissues, I cannot see any epithelial component. So, yeah. So can I diagnosis of the malignant phylloides tumors without epithelial component in this case?
In this case, I think you can. And I think that you can, and some of my colleagues, when they have come across, in those cases in which I know that there is a good, or rather, reliable kind of clinical history that there's a phylloides tumor, I have said recurrent, phylloides tumor in a comment say, because I don't see, because there is no, despite the fact that there's no epithelial components, I'm seeing stromal overgrowth, malignant differentiation, that this is likely is a malignant phylloides tumor and it's clinically recurrent. Some of my colleagues have put in, malignant spindle cell proliferation or, atypical spindle cell proliferation, and then in another comment say, this is consistent with recurrence of the patient's known phylloides tumor. Because sometimes in these cases, I don't know if it was with your case, in which the phylloides tumor starts out as borderline and then it kind of recurs, but it's the stromal component is the one that usually recurs with it. So you're not really sure, do I call it malignant phylloides tumor? Do I call it recurrent phylloides tumor? What I'll say is that this is, a recurrent phylloides tumor, and, based on the designation of what I'm seeing in the recurrence, that it can be considered malignant. It probably doesn't add that much more information other than, you have a recurrent phylloides tumor, but, because at that point it is one that's clinically aggressive. But I'd still just say I'm not seeing these things and everything is compatible with a phylloides tumor. But if some people who are uncomfortable and they either don't have that history or the history is from a while ago, they have been known to say like atypical spindle cell lesion, and this is in a comment, it's compatible with recurrence of the patient's known phylloides tumor. I don't know if that made any sense. It's a lot of words just to say, I think what you did is perfectly fine.
Okay, thank you. At that time, I put the diagnosis as like a high-grade pleomorphic looking sarcomas that suggest of the recurrence of the malignant phylloides tumor without any epithelial component like that. Yeah.
I think that's perfect. It's just as like, had we not had that history, it's funny, the diagnosis is a lot more tricky when you have to figure out what kind of sarcoma is this. But I think that is probably the perfect way to say it.
Okay, thank you, sir.
Okay, thank you so much for the questions. And now we will move to the case discussion session to explore some practical applications of today's lecture topic, in which Dr. Andrew will guide us through real-world-based fibroepithelial lesions examples. This is a great opportunity to engage, ask questions, and discuss your thoughts with our expert faculty. Please welcome again Dr. Andrew.
Thank you very much. And I am sorry if I'm already starting to go over my limit a bit, but my time is your time. I don't want to make it too much because I know that everybody is very busy, but I am at your service. And hopefully, this is something that can be helpful. So I am happy to provide, in one way or the other to kind of get these slides out to you. But here is sort of our case discussion. And then what I also did is I included a kind of a PowerPoint, which kind of gets into the salient points of what I wanted to get at. So just one moment, almost there. I think that my knowledge of computers ended at the Nintendo Entertainment System. So a lot of this stuff is amazing to me, and it makes me feel a little old. Alrighty, and then one more thing, it will go to slide sessions, and we'll go to, okay. Well, hopefully you find these cases interesting. Most of these cases I just chose to illustrate points rather than to show something interesting. But first, let's just start with what we have right here. Are you able to see kind of the scanned image? Oops. Okay. So here we go. Here is an example of an excisional biopsy in a patient who had a fibroepithelial lesion. So this was from a 32-year-old woman who presented with a breast mass. A core biopsy was performed, and the diagnosis just said atypical ductal hyperplasia. And we'll kind of see as to what led to that. And it didn't make much sense to the radiologist because what they were going for was a mass rather than calcifications or distortion. But the diagnosis just said atypical ductal hyperplasia or ADH. So here we go. This is the excision specimen in which we have this fibroepithelial lesion on one part of the slide, and then some other kind of stuff, which looks like it could be an intraductal papilloma or some sclerosing adenosis. So I kind of do the same thing that almost certainly that you do, and that's just starting from the low power and going to the high power. I can tell that this is a circumscribed lesion. It seems to have a very sharp interface between the fibroepithelial component and the background breast tissue. It's a little busy over here, and we'll try to determine why was this thing called ADH instead of a fibroepithelial lesion. Okay, so I can tell from this standpoint that it looks like it's pretty circumscribed. It's easy to find epithelial elements in here. There's no areas that look like stromal expansion or stromal overgrowth. I mean, if I can't see stromal overgrowth, at kind of like almost a 1x field, then I'm not going to find it at a 4x field. Let's take a look now at kind of the stromal cellularity. And it seems to be pretty evenly distributed throughout the lesion. There's no areas in which it looks like the epithelial components are kind of pushed apart by areas that look like stromal expansion. It seems to be pretty normocellular, meaning that the stroma looks pretty similar to a normal looking fibroadenoma. Then kind of going on a little bit more higher power, the cells look very normal chromatic, meaning I don't see anything that looks like nuclear hyperchromasia. They're not really that big. They don't seem particularly hypercellular, and I'm probably not going to find a lot of mitotic figures in here. So to my eyes, it looks like a fibroadenoma that has maybe a little bit more on the epithelial side, but otherwise nothing that looks weird. So the issue with this case is it looks like to me like a fibroadenoma. And then we have this spot over here. Oops, a daisy. There we go. It's about as fast as my brain is, which is not that fast. We have, and I think this is a case that I shared with some of your outstanding trainees that came over here, fantastic knowledge base, is we have an intraductal papilloma, some apocrine metaplasia, and then probably this is the area which caught the eye of the person who looked at the biopsy, because it looks like it has some cribriform growth. And it's an intraductal proliferation. It has nothing to do with the fibroadenoma. Now, on one hand, it does look like cookie cutter spaces and something in which I would think about the possibility of atypical ductal hyperplasia, but there's something that's funny about it in that it has all this kind of squiggly material and this extra thick kind of basement membrane material that is within it. So it's not really like an epithelial proliferation. It's probably a myoepithelial proliferation that's more along the lines of collagenous spherulosis rather than atypical ductal hyperplasia. One of the things that comes up sometimes with collagenous spherulosis is the possibility of an adenoid cystic carcinoma, but this all seems to be pretty much intraductal, associated with an intraductal papilloma, nothing that looks infiltrative about it, and it just so happens to have gotten caught up in the background of a fibroadenoma. So just to kind of go over the salient points in this case, here we have, oops, a daisy, let me go to we have a well-represented glandular component. The stromal component is not cellular. We have this, it's very well circumscribed. Right next to it is kind of the more interesting part of the case, cribriform intraductal process. No overgrowth, no periductal stromal hypercellularity. It's this patch-like arrangement with these slit-like spaces that almost look like blood vessels but don't have any red blood cells in them. And then my favorite part, which is one of my favorite intraductal lesions, is this cribriform arrangement, a lot of excess basement membrane material, this spidery, squiggly stuff in here, and it represents a myoepithelial proliferation. So the summary is we have a fibroepithelial lesion with an evenly distributed glandular component, circumscribed growth pattern, no stromal hypercellularity or atypia, not even bothering to count mitotic figures, but they are not They are very hard to find, and there's no heterologous sarcomatous elements. So all the fun stuff is in this intraductal papilloma. And this is a fibroadenoma with an intraductal papilloma and collagenous spherulosis. And if you put these things together, you could call this a complex fibroadenoma. Just because complex fibroadenoma to our clinicians usually means, wait a minute, what is this? Why is this worse than a normal fibroadenoma? I tend not to do that. I tend to say fibroadenoma with including an intraductal papilloma or with an adjacent intraductal papilloma, just to kind of make it not sound as dangerous. Complex always makes it sound a little bit funny, and I've made that, and I found that out the hard way. In a case in which I called a complex fibroadenoma, I got a call from a surgeon. He said, well, Andy, should I excise this? I said, no, this is just a regular fibroadenoma, and I am very sorry for the confusion, but that's pretty much is what it is when you, a complex fibroadenoma, when you have some other type of proliferative breast changes, sclerosing adenosis, or an intraductal papilloma. So fibroadenomas can be associated with other proliferative lesions. You could call this a complex fibroadenoma, and it's of no clinical significance, and the ADH was probably just collagenous spherulosis. Okay, now let's get to case number 2. All right. Any questions with that case? You can either ask them now, ask them whenever you'd like, ask them while I'm talking, whatever is the easiest for you. Okay, let's get to case number 2. And here we go. So case number 2, this is from a 42-year-old patient, whoopsie-daisy, who presented with a breast mass, and the core biopsy was performed and was diagnosed as a cellular fibroadenoma. So let's take a look at what we have here. Okay, so just kind of going about this through the usual kind of way. It's a fibroepithelial lesion. It does have some kind of more broad and leaf-like growth, deeper epithelial clefts, but it's circumscribed. There's nothing that looks like infiltrative growth. It just has more of a prominent stromal kind of component to it. Now the stromal component, let's go down to 2x. So at least in about a 2x field, we can still see that the epithelial component is visible in everything. So there's nothing that looks like stromal overgrowth. But there's some areas that have this more fascicular growth pattern, a little bit more cellular. They almost remind you of something that has smooth muscle differentiation to it, something that looks like a leiomyoma. In terms of individual cytologic atypia, the cells might have a little bit of hyperchromasia, nothing that looks really too significant. Otherwise, there's no pleomorphism. Well, maybe occasional kind of cell that looks a little multinucleated, but in general, not a lot of pleomorphism. It is hypercellular. There probably are increased mitotic figures in here, but they are kind of hard to find, meaning they're probably not any more, or at least for this thing, than 4 to 6 per 10 high-powered fields. I don't see anything that looks like heterologous elements in the form of osteosarcoma, rhabdomyosarcoma, or liposarcoma, and nothing that looks like, as defined stromal overgrowth. So let's take a look at kind of what our conclusions are. So here we have fibroepithelial lesion, circumscribed growth, but there's more space in between the glands, and in that way I'll refer to it as expanded stroma, but not stromal overgrowth, not as defined as in a 4x field. Leaf-like growth, deep epithelial clefts, mildly hypercellular stroma, but there's nothing that looks like stromal overgrowth. Fascicular stromal cell architectural arrangement, so it kind of looks like a smooth muscle process. There are mitotic figures, but there are not that many of them. At least when I counted these were 2 per 10 high-powered fields. Nothing that looked like pleomorphism. The nuclei are pretty normal chromatic. They're not like odd or have, darkly, you can still see through them. So here we have a fibroepithelial lesion, mildly hypercellular stromal component. It appears expanded, but it's not overgrowth. Leaf-like growth, 2 mitotic figures per 10 high-powered fields, no heterologous elements, no infiltration. So this one I called at least a benign phylloides tumor because it seemed to check those boxes beyond, in terms of we have true leaf-like growth, we have some stromal hypercellularity, but nothing in the ways that make this malignant. And the expected behavior of something like this would be very similar to a fibroadenoma. But at least in this case, I felt like the nature of and the degree of leaf-like growth was sufficient to call this a benign phylloides tumor. So, expanded stromal compartment, mildly hypercellular, there's leaf-like growth, but still circumscribed, no stromal cell atypia, rare mitotic figures. Benign phylloides tumors behave more like fibroadenomas when completely excised. Recurrence potential is very similar, and patients do not need to have wide margins. Okay, so let's move on to case 3. This is a 6-year-old patient who I don't know the size of the mass, but it was described to me as enlarging. And now let's go back to our slide and move on to case number 3. Okie dokie. So already from very, very low power, we can tell that this doesn't really have a very well circumscribed growth pattern. It seems to be eking and infiltrating, at least, into background benign breast tissue. Sometimes it's in this nodular form, sometimes it's in this kind of infiltrative, almost moth-eaten form. And we also have areas that look like leaf-like growth and periglandular stromal hypercellularity. So there's a lot of information we can get from this just from the big low power view. Okay, so we have some of this infiltrative growth, we have leaf-like areas, we also have stromal hypercellularity. Now let's take a look and see what kind of stromal cell atypia and what type of, how many mitotic figures are there. So if we were to look at this area, these cells are plump, they have an increased nuclear to cytoplasmic ratio. There is very mild pleomorphism, but nothing along the lines of like outright malignant look to them. There probably are mitotic figures in here. Again, I won't waste your time by counting. What I usually do is I will kind of find, just scan through and see how, if I can land on a field that has mitotic figures in it, and I will start counting there. Ideally, if you're able to start your field with more mitotic figures, almost what they call the Stanford way of counting, so that if I come across something and I say, all right, I can start counting here because I see 3 mitotic figures in one field, then I will start there and then move to random directions. So kind of what has been described as the Stanford way of counting, and that's how it's been done, especially for atypical looking smooth muscle tumors of the uterus. So there is pleomorphism, there's hypercellularity, there's periglandular stromal hypercellularity, there's infiltration, but I don't have along the line anything that looks like true overgrowth. We'll kind of go through it here. Fibroepithelial neoplasm, it's infiltrative. Distinct periglandular stromal hypercellularity, so that's kind of a ominous sort of feature. Hypercellularity extends away from the glandular component. There is stromal cell atypia, hyperchromasia. There is nuclear pleomorphism, but it's pretty focal. And in this case, I could get to 8 mitoses per 10 high-powered fields. And this is what I mean, is that I would start on a field like this in which I can find at least 2 mitotic figures, and this one looks a little bit atypical. Now, atypical mitotic figures don't come into specific grading criteria for these, but I think that all of us would agree that if you see a funny-looking mitotic figure, it just makes you look extra hard for other things. Some of the old-school pathologists would say, well, you can find mitotic figures in anything, and you can even find benign things with atypical mitotic figures. But I'm a superstitious individual, and I think that most benign things don't have atypical mitotic figures. So this is something in which I just store in the back of my head and say, all right, Andy, this could be something more than just a benign fibroadenoma. So hypercellular stromal component, but no overgrowth. It's infiltrative. There is atypia, 8 mitotic figures per 10 high-powered fields, but no heterologous sarcomatous elements. So there are areas of this that look malignant, like the stromal component, if you took out all the glands, would look like a sarcoma. However, I can't check every single box in the malignant phylloides tumor sort of category, so it goes into the borderline phylloides tumor. And the significance of this is that wide surgical margins should be discussed, but that's something that only the surgeon is going to be able to do. There is a cosmetic kind of cost that comes along with achieving wide margins. But at least at our institution, and probably a lot of the others, most surgeons will aim for wider margins along the 1 centimeter line. They have recurrence potential, but not expected to metastasize. Okay, let's move to case 4. This is from a 33-year-old patient who presented with a very large breast mass. And by a very large breast mass, I mean it took up most of the breast. The core biopsy was performed, and the diagnosis was a spindle cell neoplasm. Let's go to our case. And here we go. So that's amazing how, I think this is the case that I'm looking for. Okay. It is pretty crazy to see how much these things can vary just at low power. We have this kind of this breast tissue in the background. Then we have something that kind of looks fibroepithelial, and then something over here that looks awful. That has necrosis. It's very cellular and very scary looking. So we won't pay as much attention to this benign kind of breast tissue. But the only kind of advantage we have is, well, it just kind of serves as a nice compare and contrast as to what kind of stromal cellularity the patient has in the background breast tissue, and it's not that much. And it certainly contrasts with what we have here, in which there's clear stromal hypercellularity with periglandular condensation or periglandular hypercellularity. It's expanding the epithelial components, and it's getting harder to find. And then right next door, it seems to transform into this terrible looking neoplasm with coagulative necrosis, conspicuous nuclear pleomorphism, and clearly something that would be along the lines of stromal overgrowth in this more necrotic area, in which I can't see any epithelial components in a low power field, which would be 4x, but even higher than, or lower, I should say, lower power than that, 1x or 2x, or even just with the naked eye. Alrighty, so this one is pretty straightforward, and again, just going from a low to a high power sort of view. Here we have a cellular spindle cell neoplasm with necrosis in its worst areas. I wouldn't know what to call this thing if I didn't have some of the other components in the background. And no wonder why it was called a spindle cell neoplasm, because the differential diagnosis for something like this could be very broad, and you would have to think about the possibility of metaplastic carcinoma. So the fibroepithelial component was observed only after extensive sampling. I did not do any immunostains on this because I know that there are pitfalls in that interpretation, and that it's probably better just to oversample something like this in hopes that you can find a component that resembles something that looks fibroepithelial, and that's your only surefire way of being able to separate a malignant phylloides tumor from a metaplastic carcinoma. The recognizable fibroepithelial zones, and they are also atypical. And then it just goes nuts with a sharp contrast between the fibroepithelial part and then areas that are overgrown and clearly malignant. And this is actually the case in which it looked like a kind of almost like a adrenocortical neoplasm with these small little microvesicles. And there's also coagulum necrosis. So this one checks basically all the boxes. I might not be able to see heterologous sarcomatous elements, but by that time, I can get almost everything else here. It's hypercellular. Growth pattern is difficult to discern, but it's replaced the entire breast mass. So whether it's circumscribed or not, it's enormous. There is stromal overgrowth, coagulative necrosis. Fibroepithelial zones were only apparent after extensive sampling, over 20 mitotic figures per 10 high-powered fields. I essentially knew that this was going to be a malignant neoplasm, and it made me put this into the phylloides tumor category only after I was able to see this component. So the clinical significance of something like this is the major differential diagnosis is metaplastic carcinoma, and there would be a treatment difference. Metaplastic carcinoma patients would have the option of receiving adjuvant chemotherapy in this case, whereas it's a little bit more difficult, that decision-making for those with malignant phylloides tumors. Some of them have received chemotherapy, others receive just radiation to the field if there's a close margin. So we make the diagnosis when we can check most of those malignant boxes that we see in the WHO. Overall, the behavior is difficult to predict, but metastatic sites include lung and liver, lymph nodes, long bones. Interestingly, though, most cases might recur, but they do not necessarily metastasize. Okay, this next case is an interesting one. It's from a 78-year-old man who presented with multiple breast masses, and we'll move on to let's see, actually these are a little bit out of order, but we'll move to this. It's case 7 on here. Okie dokie. So from low power, I think the one salient thing is I'm not seeing anything that looks like recognizable phalloides architecture to it. I don't see any epithelial component. And it's kind of subcutaneous. Okay, that can happen. It's a male breast. They don't have as much breast tissue. So some of these things tend to look like they're more subcutaneous. But I don't really know what this is because I don't have that background component of a phalloides tumor. And I would have to just kind of rely on extensive sampling in order to know what this thing is. But because of that, I have to consider the possibility of other sorts of lesions. So let's just say that this was representative of what we were looking at. And the fact that I can't find any breast tissue meant that there probably wasn't breast tissue in the background. Okay, so I have to increase my differential, or I have to widen my differential diagnosis and think about other entities. The cells in here look obviously malignant. There's mitotic activity, lots and lots of nuclear atypia, a little bit of pleomorphism in terms of multinucleated, lots of cytoplasm, kind of this pseudofascicular growth, coagulant necrosis. I know this thing is malignant. I just don't know what it is because I don't have anything that looks fibroepithelial in the background. So these are the ones in which I'm grateful for clinical history. Here we go, just kind of reviewing. Highly cellular spindle cell neoplasm. It's subcutaneous. Infiltrative, can't find any fibroepithelial zones, and it's really ugly looking. So this patient is what we would call this, I don't know what this is. It's a malignant spindle cell neoplasm. Well, this patient had a history of melanoma, and in this patient's case, in this history can be a pathologist's best friend. The patient did have this history of melanoma. Neoplastic cells were strongly positive for S100 and SOX10, which would be negative in a malignant phalloides tumor or metaplastic carcinoma, I'm not so sure about, but when you have diffuse S100 and SOX10 staining and any sort of spindle cell lesion, melanoma must be number one on must be high on your differential diagnosis. So I didn't know what this is. And I think the pitfall for something like this, particularly for an individual like me that wants to classify everything, is just saying, it has to be either a metaplastic carcinoma or a malignant phalloides tumor. But there are other things that are malignant in spindle cell. And in this patient's case, there was a history of melanoma, which was able to lead to the diagnosis. Okay, case 6 is from a 30-year-old patient who presented with a 2-centimeter breast mass. Let's move back to our slide. So this is a core biopsy case, and this kind of reflects one of the questions that we were kind of getting at. What do you do when you have something that looks like a funny-looking fibroepithelial lesion, or at least what are some of the strategies coming to a diagnosis? Okay, so from low power, it's a little bit more cellular than what we're used to in a typical fibroadenoma. But I understand that to everybody looking at cases like this, they'll say, Andy, you're nuts. I think that this looks like a regular fibroadenoma. Or other individuals say, Andy, that really is making me worried about a phalloides tumor, even a borderline phalloides tumor. Well, one way or the other, it looks cellular. And it doesn't have kind of the nice, well-defined intracanalicular or pericanalicular growth. That said, I can still see epithelial elements in here. It's a little bit harder to define the growth pattern, and I don't know to what extent the stromal is proliferating because it's just a core biopsy. Let's take a look at some of the cytology. The cells are plump, otherwise are pretty normal chromatic. No kind of cytologic atypia. And I'm sure that, again, that there are mitoses in there, but there's probably not that much. Maybe every now and then we get a larger, kind of more round cell. But a lot of the darkness, I think, that comes in these are either lymphocytes or kind of the picture that I took is not very good, and it's just more along the lines of they're a little bit darker. But nothing that looks pleomorphic. They look a little bit more plump. I'm not seeing overgrowth, just an expanded stromal compartment. Well, at the Cleveland Clinic, we have a pretty conservative approach to stuff like this. So just a review, fibroepithelial neoplasm with cellular stroma. You kind of know what direction this is going to go into. Expanded stromal component. Glandular elements are still easy to find. They're just a little bit more spaced out. Degree of stromal cellularity is similar to the ovarian cortex. So it's cellular, but not super duper cellular. Pash-like stromal architecture, plump cells, normal chromatic, nothing that looks like atypia. This ended up putting in the cellular fibroepithelial lesion. So term when we are split between a fibroadenoma and some sort of phylloides tumor, usually benign. Clinical correlation is necessary, and there's really no getting around this. Even actually, if you were to do molecular testing on this, and you were to find like a MED12 mutation, it has no clinical significance because you could see that in a fibroadenoma as well as phylloides tumors. So this is kind of getting back to the question that I was asked. I apologize if I can't remember names. I'm barely able to remember my names or my name on a good day. But this is just one where the degree of stromal cellularity was more than what we would expect in a straightforward fibroadenoma. So we flagged this, and this is kind of the best that we can get at. And actually, I don't know how this lesion is going to turn out because this one has yet to be, the decision was not to excise on this patient. Okay, then we will move to case 7. And I want to make sure that I'm not screwing things up time-wise. Okay, I think I'm still okay. All right, let's take a look at our slides. And if there's some way that I can get these slides sent out to you, I will do my best to do that. I am happy to send the PowerPoint things as well. Whatever is sort of easiest, because I know that's a lot of material in a short amount of time. Okay, so here's this lesion. This was from a patient, a 21-year-old, who presented with a 2.5 centimeter breast mass, and the core biopsy was performed, and the diagnosis was a cellular fibroepithelial lesion. So we have kind of a fibroepithelial lesion, and although it's hard to tell in this, you get the feeling that there's pushing growth and that there isn't anything that looks infiltrative. For the most part, the glandular component is pretty well defined, and there's no areas of stromal kind of expansion, maybe a little bit in this area, but who knows what the significance of that is. There is some deep-lined epithelial clefts kind of in spots like this. Now, it doesn't look quite as kind of prominent and distinct as it did in case number 2, in which they were really, really, really deep and very well-defined kind of fibroepithelial growth. It's kind of like a cross between what we saw in the first case, right here, and case number 2. So moving back now to the present case. So it's a little expanded, some leaf-like areas, but it's not exactly diagnostic of something like a phylloides tumor. So you can kind of probably guess at what else we're going to see. It doesn't look like there's any periglandular stromal hypercellularity, no cytologic atypia, at least when I'm going through slides like this, or areas like this, it does not look like that there is increased mitotic figures. So I could see somebody calling this a fibroadenoma. If somebody had called this a benign phylloides tumor, I would not disagree with that diagnosis. It might be a little bit more aggressive than what I have, but this is clearly some sort of benign fibroepithelial lesion. So what do we do? And this is something that is almost ubiquitous in signing out of breast lesions, is a fibroepithelial neoplasm that's almost a perfect hybrid between a fibroadenoma and a benign phylloides tumor. So just to review, glandular component is easy to pick out. Stroma appears cellular, mildly expanded in some areas, but not to the point of anything that looks like a big leaf-like growth. Some, but not like big maple leaves, kind of more along the lines of petals. There is no periglandular stromal hypercellularity. There's nothing that looks like atypia, kind of that more pash or ovarian stroma degree of stromal cellularity. Plump cells, no conspicuous mitotic figures. So I bet you, and even if you were to ask me, I would be split between calling this a cellular fibroadenoma and a benign phylloides tumor. And for these cases, I kind of split it again, as is you will also find in the WHO, is calling these things a benign fibroepithelial lesion, neoplasm, in which there are overlapping features of a benign phylloides tumor and a cellular fibroadenoma. Most of these things, like the vast majority of these, behave like fibroadenomas. There's really no recurrence potential when they're completely excised. It's just that there's going to be both intra and inter-observer variability when it comes to whether we want to classify this as a fibroadenoma or benign phylloides tumor. So we split the difference again and just say benign fibroepithelial neoplasm, see comment, and in the comment says there are features overlapping, fibroadenoma, benign phylloides tumor. The expected behavior of a neoplasm like this is similar to a fibroadenoma so long as it is completely excised. Okie dokie. Any questions regarding these cases? I know it's kind of fine through a lot of content, but there's really is not much of a difference between how we kind of judge or classify what these lesions are. We start from low power and go down to high power, and a lot of times you can predict what the high power is going to look like on the basis of low power features. Any feedback or or any questions or anything for clarification, I'll be around. I'm happy to do whatever. But hopefully there's stuff that's helpful in here. But your shared experiences also would be very important to me as well.